Sir, the child may have neglected Montesia fracture. The two characteristic findings are one is the radial head dislocation, and prominence. Sir, we do in this case we do open reduction, open ulnar osteotomy, and do open reduction of the radial head, relocation of the radial head with annular ligament retying.
We can see that the ulna is deformed, the plastic deformation in ulna. So if you draw the Mubarak line, it doesn't come in line with the.
Okay, left side neglected Monteja fracture dislocation. You can even talk of Bado's classification since it's anterior Bado 1. Radiocapitular line broken, Mubarak's line broken, not straight. And then what do? Ulnar lengthening procedures. So you can do an osteotomy, angulation or step cut. Then we need to, once we do that, usually radial head falls back. So you confirm whether radial head is fallen back. If it's not fallen back or if it's unstable, you might require an ligament reconstruction. Again, depends on how neglected it was. Okay, but this is how you answer in your exams, that you are addressing the ulna, you are addressing the radial head. That's it. Okay. Fine. Next.
40-year-old man presented to tertiary care hospital after lavage and suturing of the injured limb at a primary center. What is the diagnosis?
So there is a clinical picture, there is a radiological picture.
Yeah, this is a open calcaneal fracture, tongue type by classification.
Good.
It seems to be type 3A open fracture because wound is approximate.
Yeah, but technically you don't use those gustula Andersons for calcaneum. Right? You can just tell it's open fracture
Open
of
fracture,
calcaneum
open calcaneum.
because you are seeing the wound and the history is there. You spoke about tongue type fracture. All right.
Yes, sir.
Next question.
What should have been done in this type of injury?
What should have been done in this type of injury? So again, what should have been done? What should not be, it's not what should be done. What should have been done? It's a clue.
What should have been done?
A 40-year-old male presents to a tertiary care center after lavage and suturing of his injured limb at a primary center.
Sir, emergent reduction of the fracture and fixation in the because it is causing skin flap necrosis, the fracture fragment.
That's it. And what do you do to the open wound?
Sir, we wait. We provide external fixation and then manage it secondarily. Not for the wound. When the soft tissue conditions improve, then we go for suturing.
Okay. You're still not slightly getting. What should have been done is the question. So you need to do something, right?
Sir, we should leave the wound open, and we should put external fixator with foot frame. And we should put external fixator with foot frame such that once the wound heal, then we can plan for further management.
Sir, only wound wash and debridement should be done in the first stage.
And
I think it has been done.
Fracture?
It has been done.
That's what they did, right? Lavage and suturing of the injured limb. That's what they did. And still it's come to an OSCE question. So that's something different that you should have done.
Thorough lavage, K-wiring and slab in coinage position.
Okay. Fine. So, all of you put together, you have got the answers. Right? Tongue type fracture, this is actually an emergency. What do you see? Because if you leave it long, then it's going to cause skin necrosis. Okay, this has to be emergently reduced and fixed. K-wire screw again preferred. Screws are preferred over wire. Okay. And what needs to be done for the wound is wound debridement, lavage, appropriate things that you do for the wound. You don't need to put on X-fix for this. Okay. So Mike.
Just two questions in this station. One is 2 marks, one is 3 marks. You just can't write one line. You have to explain. You have 5 minutes for one station. So the examiner is thinking that you write something. So he wants something for the open fracture. He wants something for the fracture. He wants something. How would you fix if you are saying that you will reduce and fix, how will you fix? So all those things would have, this is our thought process.
Correct.
That
So
this would need to be mentioned in your, this would, if I am to frame the keywords, I would frame that.
Yes, your keyword should have been an emergency reduction and fixation, which will be the first keyword, because that takes priority over everything else over here. Your for the wound wash, lavage, debridement, and your other tetanus prophylaxis or antibiotic prophylaxis, all those things you need to mention. Okay, so that completes. But I think the keywords will be the emergency reduction and fixation. Okay. Right. So that's how you could frame your answer. Most of it is discussed. Yeah, okay. Next.
This picture is a 60-year-old man after surgical exposure of total knee replacement. X-ray of the spine is as shown. First question, what is the diagnosis? What is the basis of this appearance of the knee?
You can read the full question actually.
Yeah.
Maybe so there are sometimes clues in the rest of the part. So you can read the rest of the whole station you can read.
The second question is, name the single pathognomic features seen in the X-ray. The third one is, what are the confirmatory tests to diagnose this condition?
What are you seeing?
It is a case of ochrochronosis, blackening of the tissue. Kleptonuria.
What tissue? Blackening of what tissue?
Bones and cartilage.
Bones?
Cartilage.
What is the diagnosis? What is the basis of this appearance of the knee? What is the basis of this appearance? You said your diagnosis is ochronosis.
Yes, alkaptonuria.
Diagnosis, that is diagnosis.
Yes, sir.
What is the basis of this appearance of the knee? Why is this? You said cartilage is black.
Yes.
Why? आगे pass on.
Deposition of a HGA on the cartilage on the
HGA क्या होता है?
Homogenetic acid.
Genesic acid.
Genetic acid.
Okay.
Yes.
Yes. Go ahead. Go ahead.
Single pathognomic feature seen in the X-ray.
Sclerosis of the
Sclerosis of the
increased joint
disc.
space.
Sclerosis of the
Disc, sir. Intervertebral disc.
Any better word? Any
very
better
word,
word?
that's what the keyword is missing again.
Better word. It's sclerosis. Sclerosis होता है? हड्डियों में होता है? What happens to the disc?
Calcification of the disc. Sir.
Okay.
Increase in the density of the.
Okay, next question.
What are the confirmatory tests to diagnose this condition?
Urine
Again, question,
24
read the question, what are the confirmatory tests?
24-hour urine HGA test, sir.
Okay.
For diagnosis of alkaptonuria.
I think they're asking for
More tests. They are a plural.
At least two. At least two. 2 marks, right?
So when they have asked tests, you need to write at least 2. Forget the marks.
This is more of a biochemistry question rather than. So you can give chronosis also answer, but it can be alkaptonuria. Both you can say it is because of the deficiency of homogenetic oxidase enzyme that which oxidizes homogenetic acid. Because of that, it gets deposited. Where it gets deposited, gets deposited in the cartilage. Wherever the cartilage you see, whichever part of the body open, you see this blackish color. Along with that, if you see a synovial, it will be all blackish. Okay. And important thing, the other clue is in the X-ray. There's only one X-ray image, right? So there you can see a calcification of the disc. There's a classical finding. That's a pathognomic finding. And what is the confirmatory test? There are two important tests. That is appearance of change of color of urine when you expose to sunlight. It's not 24 hours. It is change of color of urine after the exposure to sunlight. The other thing is skin biopsy, where you see a deposition of pigment into the skin, because the skin is again exposed to the sun. So skin biopsy and the urine color change is the confirmatory test. Before solving any OSCE question, try to just don't read the question at all. Try to read all the parts of the question. Okay, just reading the statement and trying to answer, you will not get the clue. Start analyzing each and every question so that you will come to know what the examiner is expecting you to answer that. And see the marks given for that, 1 or 2 or 3. If they are giving more than 1 marks, that means your answer should be not more than, it should not be less than one sentence or one point. Okay, it has to be more than 1 point. Fine, we'll go to the next.
Yeah, urine turns black is one of the things seen, okay, but you can measure the homogeneous acid also, so that is also a confirmatory test. So both you can write if you want, and skin biopsy, okay.
You can also see the sclera, the pinna for blackish discoloration. So that is also a clue.
Correct, but
Confirmatory test.
But confirmatory test is what is asked. They have not asked you signs. Again, read the question what they have asked you. Okay, so those are all the signs that you see.
Okay, next one. Who wants to take this?
This 15-year-old patient had a non-union of fracture neck femur for which a valgus osteotomy was done, which also failed. This was revised with a THR. Name 2 striking radiological feature in X-ray A and B. Name 4 special consideration for planning a revision surgery. Sir, in X-ray A, the fracture was not reduced. There was not anatomical reduction of the fracture.
No, they have mentioned it's valgus osteotomy done.
Sir, there is avian of head of the femur.
Okay, you continue. They have asked you for 2 abnormalities. You tell the way you will answer.
In X-ray A, we can see there is avian of the head of the femur. And in X-ray B, we can see there is non-union of the neck of femur.
Good. 2 most important, yes.
Okay. Mention 4 special consideration for planning a revision surgery. 4 special. Sir. I'm not able to recall it.
Sandhus.
Good. So, usme what are the points?
Absorption of head and sclerosis of the fracture margin.
What else? Is there any avascular necrosis or not? Size of the
head,
Mhm.
then surface of the fracture, so whether it is sclerosed.
Those would be the considerations that you would think of when performing the next revision procedure, right?
Yes.
Anything else? Next person. I think you can go ahead.
Okay, so in this they have asked you a typical scenario that a valgus osteotomy was done and that failed. And now you need to revise it to a THR. So in that particular scenario, what are the considerations that you need to take? So imagine the valgus osteotomy is done, that means alignment is shifted now. Okay. You have to do a THR now, your trochanter and your shaft canal are not in line. That usually happens in the valgus osteotomy because there will be a slight medialation of the shaft. Okay.
Sir, one consideration will be the previous implant and the stress rise.
Louder, louder.
Sir, one consideration will be the previous implant and the stress riser. So the THR stem should bypass the.
Okay, you can write about that. That is one point. Okay. The many issues, I mean, you can talk about everything. So they have asked you 4. So that is one good point.
And the age of the patient is 15-year-old.
Mhm.
So it's better to have a proximal fitting S-ROM type of stem so that if there is a revision, we can just replace.
Okay.
That you can see X-ray put up, right? Any clue?
Say start analyzing the X-rays. If you are finding it very difficult to read these X-rays, okay, start seeing from the SI joint. Is there an abnormality seen in the X-ray? SI joint, no. Iliac bone, nothing. Acetabulum, supracerebellum region, nothing. Sclerosis of head is seen. Neck is resorbed. Okay. What happened to the level of lesser trochanter on both the sides? What happened to the level of lesser trochanter on either sides?
It's the right side.
Even after doing a THR, what is the level of lesser trochanter?
External rotate.
No, okay. Rotation higher up. Okay. There is significant shortening. Okay. Once they do the valgus osteotomy, the version and the offset of the hips are changed. Okay. The version of the femur is changed because along with that they don't even just valgus osteotomy. Sometimes they will be combining with the rotation. So there might be a version problem. Okay. And the offset is problem. So that is the reason they have gone for a modular stem. That is a clue given in the C, option C. That's an S-ROM stem that was supposed to be the metaphysis sleeve. Usually sits on the lesser trochanter, but this is also an accepted way of putting a stem, right? Because that version is changed. That's the reason they have gone for dialing up a version. As you said, to bypass the last cortex, they have put a longer stem, and the offset is reduced. So they have gone for a low offset stem. Okay, these are the things. Along with that, there are other things. Whenever you see a shortening and you want to consider for THR, okay, there are chances that you may have to release extensive soft tissue. One of them is doing an adductor tenotomy. That's the first step. Okay, so you do the adductor tenotomy to get the length. To even that offset is reduced, so you have to go for a shorter offset stem. And version is difficult. You need to dial up an version so that you can go either cemented stems or the stems which has got modularity of version. Okay.
There point 4 you can write for any revision surgeries. Okay, there will be a scar, fibrous tissues, chance of infection is higher. That you can write it for anything. Okay, fine. Next. Pass the mic. Next.
A young adult male sustained dislocation of his elbow. Close reduction was attempted. This is the post-reduction X-ray. Mentioned 2 radiological finding. Which nerve is most at risk in this injury, and what should be the first line of management? fracture of olecranon.
There are two views, AP view and the lateral view. So anything abnormal in the AP, anything in the lateral.
Proximal ulna. Capital.
Sir, it looks like medial epicondyle has a well stand going into the joint. Entrapped medial epicondyle.
Okay. So they have asked you two radiological findings.
So one is absence of radial medial epicondyle and medial epicondyle entrapped in the joint.
Absence.
What tells you the same thing?
Same. Fracture of
One is fracture, one is something in the joint. Two findings. There's some fracture?
so it looks like a trochlea fracture also. Not
What
very
you were
sure.
saying was right. It's absolutely right what you said.
Medial epicondyle is missing because
Why would it be missing?
it has gone into the joint.
Because it's a fracture. So fracture of medial epicondyle.
Medial epicondyle fracture.
Yes. And second finding, where is it?
It's in the joint, sir.
Yeah. So joint
So
fracture fragment is in the joint.
Whenever you have a fragment in the joint, what is the type of reduction you get?
Cannot reduce it. It will be.
You will be. I mean, this is reduced, but
It's incongruent.
incongruent reduction. You can write that. Okay, incongruent reduction of the joint. On an AP you can see that. Laterally you can see something within the joint, which is most likely a medial epicondyle. Okay. Next question, which now is at most risk?
Ulnar nerve, sir.
Good. What should be line of management?
Then open reduction, removal of that piece from the joint and fix it to the medial epicondyle.
Okay, good. So all
transposition.
Okay. So incongruent reduction, this covered, ulnar now, open reduction, and you have to fix it also. Okay. And then assess again the reduction of the joint. All right. Okay, I think the video is, okay.
Take the yellow bit.
I think this should be the easiest.
45-year-old lady presented with painful movement of her right thumb. What is your diagnosis?
Yeah.
Is it trigger thumb?
Okay, good. Next.
What is the anatomical site of pathology and the surface landmark? It's the A1 pulley.
Very good. Surface landmark. Tell in the mic, tell in the mic.
Proximal to MCP joint.
What is, I can't hear you.
Proximal to MCP joint.
Proximal to MCP, okay. Anyone wants, okay, you continue. Last one, treatment modalities.
We can do needling and steroid injections.
So they asked you for 3 marks.
Conservative, physiotherapy and all. Then needling and steroid injections. And surgical release.
Okay. Fine. Trigger thumb, A1 pulley, that is at the MCP joint on volar aspect. So conservative, surgical, steroid injections, percutaneous release, open release, splints. Okay. So always before you answer, check how much marks it is asked for. If it is 1 mark, maybe you can write 1 or 2. But when they have asked for 3 marks, you need to write more options. Okay. I think this all of you should be able to tell after today's case.
Padlo by question padlo.
Next, yeah.
Read the question.
A 4-year-old boy was injured 3 months back after falling from a swing. Name of the sign elicited in the video. What is the pathoanatomical basis of the clinical sign shown here? What is the initial management for this condition at this stage? Name two non-traumatic cause of the above condition. Walkman sign.
Okay, very good. Pathoanatomical basis. Dr. Dhal told about that.
Contraction of flexor tendon. Contraction of flexor tendon के कारण fibrosis, shortening of tendon. Fixed on flexion.
Right? So, if there is something called constant length phenomena, once you flex the wrist, you are unable to, you are actually able to extend the fingers. But once you extend the wrist, you are unable to extend the
finger.
Because the tendon muscular complex is now a constant length. So that is the pathoanatomic basis. The pathoanatomic basis can be summed up as constant length phenomena.
So that keyword needs to come on this. Even if you read everything else, you won't get the marks. Okay. Next, initial management. Pass the mic to your colleague instead of giving it back.
Turnbuckle splint.
He's warned you not to give it to him, is it?
Sir, splinting.
That is wrong.
Walkman splint.
Okay.
Sorry, sir. Walkman splint. Turnbuckle splint.
Next. What else?
Sir,
Initial
second
management.
Sir, physiotherapy.
Okay. Next question.
Sir, name two non-traumatic causes of the above condition. Sir, cerebral palsy.
Cerebral palsy causing. Yeah.
Cellulitis. Sir, diabetic. So, but it will come in the trauma. Sure. Bundles.
Here, sir. This is the video of a young man who presented with history of buckling of left knee. Identify the condition, name the radiological classification for this condition, and enumerate any 3 features typical of this condition on CT scan. Lateral patellar dislocation, recurrent patellar dislocation, maybe habitual. Radiological classification. There may be shallow trochlea and trochlear dysplasia will be there, and in CT name I don't know. And And CT scan, TTTG distance will be decreased.
Good.
And
So they asked you to write 3.
trochlear shallowing will be seen correspondingly in CT scan also.
Okay.
And lateralization of patella will be there in axial cuts.
Okay. Anyone else wants to add? Some typical features seen. Okay. So TTDG is good. Sulcus angle, patellar height, trochlear can also be mentioned. Okay. Okay. Next. I think mic is not working.
Hello. An 8-year-old boy presented with the patient's limp in his right
Sorry,
hip.
it's painless limp.
Painless limp in his right hip. Nuchal examination findings are shown. What is the most likely diagnosis? Mention 4 physical signs you will elicit in this case. So there is differential rotation on the both sides. The internal rotation.
They have not asked you that. See, answer to